Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. First recording from my new home in Las Vegas, Nevada, where I moved in with my wife and kids just a few weeks ago for a new job opportunity. Apologize for the echo. My room is not exactly set up just yet. The topic of today's episode is what makes general emergency physicians nervous about seeing children. I'd like to emphasize the term general emergency physicians. I don't believe in the term adult emergency physicians, since all emergency physicians are qualified to take care of children, but it always fascinated me, why do kids make general emergency physicians so nervous? So a few weeks ago, I was invited to give 3 talks at the ACOEP Scientific Assembly, which happened to be in Las Vegas, which at the time was my future home. I took the opportunity and had a discussion recorded with my friends from the podcast EM Over Easy exactly about this topic. What makes general emergency physicians nervous about taking care of kids? I'd like to share this recording with you today, and I hope you enjoy the discussion.
All right, and welcome everybody to another episode of the EM Over Easy podcast. I am Andy Little, joined by my co-host, Drew Calno. Drew, how are you?
I'm great, Andy. How are you?
I remembered to both introduce myself and Drew in the same time, which is, I'm sure, makes Drew a little happy.
This is a first.
Yeah.
Mark this down, October 27th, 2022. The first time Andy actually introduces me on a podcast.
Yaron, Ivan is here. Yaron, how are you?
Good morning. Feeling great.
That was the worst pivot in the history of pivots, but I can't.
You just had to pivot away. It was fine. It worked out great.
No worries. Good morning.
Yaron Ivan is the host and founder of the PEM Rules podcast, which is a great show. If you haven't checked that out, head on over to penrules.com to look at all their awesome content. And then one of our blog editor and now Dr. Patricia Capone is here with us as well. Patricia, thanks for coming on. So we were approached by Yaron with this question, and he wanted us to do a shared episode. So if you're listening to this on our platform, great. If you're listening to it on PEM Rules, hello and welcome. Yaron, why don't you lead us with the question?
Well, again, thank you guys for having me, and good morning. And this is a question that I've always had in my mind after working, especially with ED residents and meeting a lot of ED docs. And I hear from a lot of general ED physicians and ED residents how pediatric patients make them very uncomfortable, and they're always very worried taking care of pediatric patients. So they're always very worried that they're going to miss something in a pediatric patient. Now, obviously, I'm biased because I've been taking care of kids since the beginning of my career. I did general pediatric residency, but in my mind, and I had my share of doing, quote, adult emergency medicine in fellowship, in my mind, my world is a lot easier than yours, and it's much harder to miss something in kids because my average patient is a 7-year-old, super healthy kiddo who has no comorbidities, essentially, maybe takes one ADHD med that doesn't really affect his physiology very much. And usually they come in with some chief complaint that is misinterpreted by mom as something serious or surgical or critical. And the chance of me missing something is pretty low. And the chance of having some bad outcome is pretty low. But your patient, so your average patient, on the other hand, is a 80-year-old with 17 comorbidities who takes who knows how many medications, and the chance of missing something or having a bad outcome is quite high. So I was always puzzled by this. Why are you guys nervous about those pediatric patients that are likely fine versus your patients that are truly sick?
I have a 2-part answer for this. So number one, like most things in medicine, and I think particularly emergency medicine, we rely on pattern recognition to feel comfortable about what we're doing. And so as you and I were talking pre-production, I see at most 20% pediatrics coming through my emergency department. So from a pure pattern recognition standpoint, I'm much more comfortable with adults because that's 80+% of what I do. Other part of that, and it's not part 2 of my comfort level with pediatrics, but the other part of that is when kids are sick, they crash fast. Adults like to slow roll their crash, and they signpost their illness and their crashing more than kids do sometimes. I mean, kids to me, the really sick kids I've had, they seem to fall off cliffs a lot faster. And maybe it, again, is pattern recognition that I don't understand the signposting of that really sick pediatric kid. Because I agree with your statement that most pediatrics, the vast majority, 90+% of pediatrics, is easy. The kid is fine. You have to just guide them a little bit. Usually it's nausea medication, it's pain control. Sometimes it's antibiotics, not nearly as often as we probably prescribe antibiotics as it actually needed. But in that less than 10%, I don't necessarily understand the signposting that comes along with it. Now, all of this also changed, though, when I had children of my own, because I now understand how to interact with children better when I'm assessing them. Before I had children, the other part of it is I just didn't know how to do a proper assessment on a child. And it's not assessment, it's interacting with them to do the assessment. How to have mom hold the less than 1-year-old, how to be goofy with a 4-year-old so they feel comfortable with you, how to act like the 10-year-old is too cool for school and that's okay, right? So all those things play into it.
Sure. No, I think those are great answers. And I can totally respect it has to do with the experience. Sure.
And for me, it's to add to what Drew said. I think the problem with kids is that, one, we're not good at reading the signposts, and parents wait so long to bring them, to where typically when an elderly patient, say, they're getting sick, like nursing homes have a very low trigger to send them to the hospital. Their family members have a low trigger to bring them to the hospital. But even as a parent, I was telling you before that I've been hoping my 9-year-old doesn't have appendicitis, and I've been sitting on him for 30 hours now. Because I'm going to wait until he's really sick to bring him in, because otherwise it could be nothing. And so why would I rush him to the hospital?
Well, I think, Andy, it's an inverse bell curve is what we see with pediatrics. Either they come in right away, like my kid had a fever for 10 minutes and I bring him straight to the emergency department, or she complained, whatever, of abdominal pain, so I brought them straight to the emergency department. Or they waited days to come in, right? There isn't they show up too soon for me to have any idea if it's anything whatsoever, or they come in as they are
truly
falling off the cliff.
Yeah, truly an extremist. And then to me, the second part is that it's the, I think of acceptable miss rates, right? So if I see an 80-year-old female who comes in for, say, shortness of breath, and she gets admitted to the hospital, I don't get the diagnosis right, I'm going to probably admit her to the hospital because she's 80 years old with shortness of breath.
Yeah, she had an 80% chance of admission the minute she walked through the front door,
and then
right?
I add that she had one low pulse ox reading and she's admitted. Where a kid, they've got, if my acceptable risk with them is basically 0. Like I can't miss a sick kid. And so just the idea that a kid comes in, they fall into that maybe sick category. Like I stress about that because I can't miss that kid. Or if I miss the 80-year-old, like I'm going to miss them, but they're going to be upstairs with the miss. They're not going to be at home with a miss.
Patricia, you probably have a unique perspective. You're a couple years into being an intern. You've seen some pediatrics. You've seen a lot more adults than pediatrics. You still fall into the 80-20 rule of adult medicine. But, what's your take?
Yeah, as an intern, obviously there's just so much that we don't know. And because we do a lot more adult medicine than peds medicine, we focus on that more, I think, in the beginning of our training. But also for me, I think, you have the 80-year-olds that comes in and they have multiple comorbidities and they're probably going to get admitted. And for me, I think just the stakes are so high with a young child, and stakes are high with any patient that you see. But I think, that you're dealing with mom and dad. There's just so many people involved. And I think just a pediatric code has the opportunity to be a lot more of a traumatic experience. We see adult codes probably once a week and maybe more. But yeah, pediatric codes, we can probably count on our hands how many times we see them in a couple months. So
no, I can totally understand the emotional component of it and the concern of missing something and sending the kid home inappropriately. I think that's where very vast and good and comprehensive anticipatory guidance comes into play. I send home a lot of kids that sometimes I'm not 100% sure, but I'm sure enough. And the parent seems responsible enough that if I tell them what to watch for and I tell them what to do, likely the kid is going to be fine. And if there's any red flags or warning flags, that the parents are going to come back. But I can totally appreciate the emotional concern and component of it.
And then as we were talking, I also thought of the other thing that I always wrote with kids, especially kids that have vague, unexplained symptoms, is that kids they haven't played their cards for other diseases yet, right? So an 80-year-old comes in, they basically have every disease they're going to have has manifested itself by the time they're 80 years old. But a 7-year-old, is this an underlying cancer that I'm going to miss? Is it an underlying endocrine problem that I'm going to miss? Is it something that won't express itself till later? Or is this their sentinel moment that I'm going to miss because it's some rare zebra that I don't want to be the one that misses it? And so no, there's just this anxiety provoking of this kid has a lot of life left and a lot of diseases to manifest itself. Am I going to be the one that misses it? And then it leads to a bad problem.
And not even zebras. Well, zebras for adult medicine, but just there's a different set of diagnosis that we don't see on a regular basis. So when you think of a 4-year-old with abdominal pain, now all of a sudden I have to think, is this, Meckel's diverticula? Is it intussusception? Is it, there's all these other diagnoses that don't happen in adults. Or here's the reality. The greater than 45-year-old with concerning abdominal pain is going to get a CT scan like before they walk in the door. It's already ordered, right? We don't want to do that to our children. So our diagnostic testing approach is different in children. So I also am more reassured by maybe my over-testing in adults, and I'm happy to admit that we overscan adult abdomens. But I'm not going to miss that rare diagnosis in an adult because I'm scanning their abdomen. I don't want to scan the 4-year-old's abdomen unless I absolutely have to. And so now that level of concern is greater, right? Because now my diagnostic testing feels more limited. And so that's another discomfort that comes with it because I'm so used to seeing no acute process or whatever process on my CT scan result as opposed to, and, you have the opportunity to work in a pediatric hospital where I imagine the ultrasound modality is widely available. I can ultrasound anybody I want, but my ultrasonographers don't do pediatrics very often at all, so they're not comfortable with those exams. My radiologists don't read pediatric ultrasounds very often, so they're not comfortable making definitive diagnoses. So now the really useful imaging modality in pediatrics is taken away from me because they'll get the images. They will not argue about getting the images, but they will argue about making a definitive read on those images.
Yeah, and I think in training for us too, it's like, okay, I learn what I need to do for adult medicine. And it's like, oh yeah, if these same symptoms presented in a 45-year-old, we would scan their belly and it's fine. So I think just from a learning standpoint, most everybody that comes through the ED gets an IV. It's like they get an IV, we get blood, and we move on. But when you go to the pediatric hospital, it's like, okay, we're not going to put this child through an IV if we don't absolutely have to. So do I really need that CBC? Do I really need that chemistry?
No, I mean, we would argue that you don't really need it in most of the adult patients we get in and other.
Probably true.
But we use those as crutches, right? And we don't have those same, adult medicine doesn't feel as though they have the same crutch when they approach pediatrics.
Yeah, you guys remind me of the story when I did adult emergency medicine fellowship, and before I signed up for the patient to see, and while I walk towards the room, the nurse finds me and said, "Hey, Dr. Even, I got you a rainbow." And that was when I was introduced to the concept of rainbows. I had no idea what a rainbow meant before that.
Well, you're just
Why
thinking
would you get a rainbow?
Thank you so much for getting me a rainbow.
Yeah.
I'm sure the patient will love it.
Yeah, and then no, but I
What's the
certainly
number for
appreciate
those?
that.
Is there, is there a leprechaun at the end of the rainbow? Yeah.
But I certainly appreciate that, and I do think that is part of that is one aspect in PEM that is a little bit more challenging. We can't really rely on blood tests and CTs, and I really appreciate when general EM physicians do the same and don't just stick the kid and don't just get a CT, but manage them more like a PEM perspective. So I can certainly see the challenge there that the reliance on testing is not as heavy.
I mean,
but that's good.
For example, I had a young, less than 90-day-old in my department that I was taking care of by myself, no resident help on it, with some increased work of breathing. Not febrile, so this is not a febrile patient, but clearly working too hard to breathe than they should. They have intercostal retractions, there's a little bit of grunting going on. Lung sounds don't sound bad. If this was an adult patient that came in with concerns for respiratory distress, and this kid was borderline hypoxic, right? I mean, we're talking, the question is it a CT scan of the chest versus an X-ray? They're getting a bunch of blood work. They're getting an EKG. They're getting a troponin, right? This kid only gets a chest X-ray. And then there's pneumonia with borderline hypoxia. And all right, well, this kid's declared themselves. They have to go downtown to my pediatric referral center because this is too young to send home, right? There's no reserve on this kid. At a minimum, they have to be observed. And this kid leaves my ED without an IV, never having had blood work. All I have is a chest X-ray. And I would have gotten an IV and I would have started antibiotics, except that by the time we had the IV and we mixed the antibiotics to give to the kid and all that, the transport team was already going to be there. So I was actually going to delay care and getting him downtown by doing it. Plus my nursing staff isn't amazing, and they get pediatric IVs more than I could ever imagine them getting them. But this is a really little kid that, so all these things. Could you imagine in the adult world admitting an elderly patient with pneumonia and all you have is a chest X-ray?
I tried to a couple weeks ago when we were admitting people from our lobby, and I called medicine. I said, "Hey, got a guy with community-acquired pneumonia or hospital-acquired pneumonia was here 3 weeks ago, has pneumonia on their chest X-ray." They're like, "What's their lab status?" Like, "They're not back yet." And like, "What do you mean?" I was like, "They're in the lobby," so I ordered them. But the only thing I have is a chest X-ray, and he's hypoxic out there on oxygen, and I figured I should probably get him. They're like, "Well, call us back on the med." I was like, I had to hold the guy for 3 more hours because it was just like it wasn't going to happen.
Right, but
with the chest X-ray.
In the pediatric world,
100%.
They're just like, "Sounds great. Oh yeah, you got a kid that young with pneumonia that's borderline hypoxic. Absolutely send to him."
Or even with no testing. I had a 5-day-old Brewy And I called medicine, like, we got to keep this kid. And I was like, I said, this is what the mom told me happened. They're like, but we'll take him. And I'm like,
it's a different world.
Happened in the adult world. And as another thing that came to mind was when Drew brought up the nursing, it's the adult nurses are great. Like, I love my adult nurses. If you're one of our nurses at Doctors or where I work now at Advent, I love you. You're great. But they get freaked out with kids.
Oh, we all get freaked out. We all get freaked out with kids.
But unfortunately, I feel like one thing that is good is that over the course of an EM residency and then working as an EM physician is that we get really good at having that duck on a pond approach, to where I'm really good at looking like I'm having a good time or looking cool, and underneath, like, nearly drowning the entire time.
Well, Andy, I don't think looking cool is actually the description. You look calm. You look composed.
Yeah, well.
Yeah, cool is...
We made 15 minutes before Drew corrected me, so I'm going to count this as a win.
That's pretty good.
That's pretty good.
That also might be a record. So mark this date again.
10/27/2022. But it's also, when we get a sick kid, most of those nurses are moms. And they view it like, I'm taking care of my kid. Or they're a grandma. And so, like, there's just a lot more emotions in the room. And I've actually been where Yaron works, and I've watched a pediatric code. And when I trained at Children's Hospital in Columbus, I'm amazed at the level at which pediatric nurses are able to keep their crap together. Mm-hmm. And so you work in an environment where that's bred, and it's not for us. And so we have, I think of the last 2 or 3 peds recesses, I spent as much time managing my staff as I did managing the patient.
Yaron, I'm curious, though, to turn the things around a little bit, how long did it take you to be comfortable taking care of pediatric patients, and then throw the adults in there also?
That's a great question. So I did my residency in general pediatrics, and in general pediatric residency, in general, you really don't see a lot of sick kids. You certainly see a lot of sick newborns in the NICU, but you do clinic. So I want to say that I loved my pediatric residency. I graduated with not a lot of comfort taking care of sick children. I was very lucky to have met in Pittsburgh for fellowship, and it was within a few weeks. I remember having my first code in 3rd month of fellowship, and I felt very comfortable. And I think one of the reasons, and it's a great question, Drew, is because in pediatric patients, and that's, again, one of the things that I tell the residents, in many ways, and you got to look at it this way, the sicker the kid, the easier it is. So when a 9-month-old comes in difficulty breathing, you basically cannot go wrong. Get an IV, give fluids, check the sodium, check the glucose, get a full set of vitals, even give prostaglandins. You're not going to go wrong. So I think when I adopted that kind of mentality or that kind of approach, things became a lot easier and clearer. But it was really, I was very lucky. It was very few weeks into fellowship.
Well, and you do make a great point with pediatrics, and something that we forget, I think, as adult doctors, is it is hard to hurt a child.
It really is.
Now, you can miss a lot of things, and that kid can go south on you, but there's really very few things you can do to a kid to make their condition worse. Contrast that to adults. There's a lot of things you can do,
and I remember
to make things worse.
And I remember, again, in fellowships doing, quote, adult emergency, and the attendings was like, what, you're going to give bolus so easily? Like, yeah, he needs a bolus. Like, no, you can give him pulmonary edema. Like, what do you mean you can give him pulmonary edema? It's just fluids.
My patients are able to pump fluid throughout their body very easily because their heart's brand new. Yeah.
The cardiac output is fantastic.
Yeah. Clearly, you haven't heard the PEF-REF and HFpEF. And...
Oh, yeah.
No idea what that is.
Oh. Yeah, see, exactly. boom, there it is.
Adult versus peds. So I guess, Yaron, if you were thinking of the listeners and us here at the table who have some of these concerns about pediatric patients, what would be your words of wisdom to us?
So that's a good question. My words of wisdom, if you're a trainee, is consider PEM, because it's great. But really, my words of wisdom is the things that we discussed. You very rarely can go wrong. The sicker the kid, the easier it is. There's a bunch of things that you can do and say and, obtain that you would just not go wrong. And it's very hard to miss something. Get into that mentality of, checking those 5-6 things that can explain sickness, hypoglycemia, hyponatremia. You can fix those very easily. And have a low threshold to give what you think the child needs. You're not going to go wrong most of the time.
I think that's a really fair description of pediatric emergency medicine. And, like everything else, it's the more you do it, the more comfortable you are. And I do think for adult emergency medicine providers, particularly when you're training, you have to have an open mind. You have to be willing to engage in that pediatric patient. It's really easy sometimes to be, I don't like peds, I'm not doing peds, and you shut off. And so just don't shut down, right? Just like when you were in fellowship and you had to see adult patients, you couldn't shut down, right?
But again, one thing to keep in mind, and that's a shout out to all trainees and EM physicians, I truly appreciate what you say, Drew. please don't manage those pediatric patients like adult. Like, don't get that CT for every kid with abdominal pain. Make them jump, get an ultrasound, use the other tools. And we do have other tools. We manage patients very well before CTs came around, but take a good clinical exam. And I always tell the residents, get a good story. So if you get good HPI from a parent, you can figure it out.
Yeah, and as someone who's had the benefit of listening to your own lecture at our program every month for a while, that is a take-home that he sends to our residents and to our attendings all the time. And if your medical students work with me, I've also done this. A good history and physical gets you 99% of the way there. And most people, and I think you would say in peds, almost all the time.
Yes, almost all the time.
I think those are words to live by in any patient you're taking care of.
Well, thanks so much for checking out this episode of the EM Over Easy podcast. Don't forget to follow us on Twitter, Facebook, and Instagram. Don't forget we are the official podcast of the American College of Osteopathic Emergency Physicians. And while you're at it, go to pemrules.com and subscribe to your own podcast, Pemrules, which is a great twice-a-month podcast that talks about ways you can better take care of pediatric emergency medicine patients.
And that is it for today, guys. Thank you very much for listening. I hope you enjoyed the discussion with my friends from EM Over Easy. Great podcast. Definitely check it out. Thank you very much for listening. Thank you for subscribing for my newsletter. Thank you for listening to Pem Rules. I hope you like the music, and I hope you like Genesis. This is one of their songs from the 90s, my favorite decade, called I Can't Dance. Hope you like it.